Hi everyone and Assalamu alaikum. This is Dr. Chaman and today we are going to discuss management of early breast cancer. So let's get started with the scenario. A 35-year housewife presents with a lemon-sized lump in upper outer quadrant of her left breast for 6 months. The swelling is non-tender but hard in consistency. There is no lump palpable in axilla. How you will evaluate this patient? Well, we will evaluate this patient via triple assessment. And what is triple assessment? It is the combination of clinical examination, imaging, and cytology or biopsy. Before moving on to the management of early breast cancer, can we recall breast cancer staging? In the last presentation, we had discussed the TMN staging. So what is TNM staging? T for tumor size, N for lymph nodes, and M for metastasis. We call it a T1 if the tumor size is less than 2 centimeter, a T2 if tumor size is 2 to 5 centimeter, T3 if the tumor size is more than 5 centimeters, and T4 if the tumor extends to skin or chest wall. We call it N0 if there are no lymph nodes. We call it an N1 if the lymph nodes, they are palpable on the ipsilateral side. We call it N2 if the ipsilateral lymph nodes are fixed, and we call it an N3 if they are infraclavicular or supraclavicular lymph nodes positive. Some surgeons also call it metastasis, like they label it M3 as M1. From M0, we mean no metastasis, and M1 means distant metastasis. After that, we will go for the metastatic workup because we want to look for the metastasis in the 4 target organs. Remember the mnemonic LLBB. The breast metastasis can go into lung, liver, bone, and brain. And we will go for the ultrasound abdomen to see the mets in the liver, chest x-ray to see mets in the lungs, a bone scan to see mets in the bone, and CT brain to see mets in the brain. You can get CT chest or CT abdomen as well to see mets in the liver and the lungs rather than just x-rays or ultrasound. So here is another staging system for breast cancer, and that is the Manchester staging system. And what does this describe? Describe the breast cancer into the 4 stages. In stage 1, disease is confined only to the breast. In stage 2, the ipsilateral axillary lymph nodes, they also get involved. In stage 3, tumor get fixed either to the skin or to the chest wall. And in stage 4, distant metastases are present. For management point of view, we divide breast cancer into 3 distinct forms. That is the early breast cancer, locally advanced breast cancer, and the metastatic breast cancer. From early breast cancer, we mean stage 0 breast cancer, that is a carcinoma in situ or non-invasive breast cancer, and stage 1 and stage 2 breast cancer. Locally advanced breast cancer means stage 3 breast cancer, in which the breast cancer is fixed to the skin or chest wall. And then we have a metastatic breast cancer, a stage 4 breast cancer. So this presentation is just about management of early breast cancer. So how you will define an early breast cancer? It is stage 0, stage 1, and 2 breast cancer. We label it as early breast cancer. What treatment you will offer for a patient with early breast cancer? Well, the best treatment will be the breast conservation surgery, which is also called BCS, with sentinel lymph node biopsy. And it should always be followed by radiotherapy. So how you define a breast conservation surgery? Breast conservation surgery is a surgery in which you remove breast lump along with a rim of normal breast tissue, ensuring clear resection margins and acceptable cosmetic outcomes. The indications for breast conservation surgery are small tumors, like a small tumor up to the size of the 5 centimeter in size, an adequate tumor rest ratio, like 1:3 will be sufficient, that the tumor size should be smaller as compared to the overall breast size. Patient should be compliant for radiotherapy because BCS should always be followed by radiotherapy. Otherwise, there is a risk of recurrence. The tumor should be monocentric, that it should not be multifocal or involving multiple quadrants of the breast. The patient should be in early breast cancer stage, like stage 1 or 2. If a stage 3 patient wants to have a breast conservation surgery, then it should be first downstaged by neoadjuvant chemotherapy. And if it is downstageable to stage 1 or 2, only then breast conservation surgery can be offered. Then we have certain contraindications. We have absolute contraindications and we have relative contraindications. The absolute contraindications include inflammatory breast cancer, the first and second trimester pregnancy, a multicentric tumor who is involving more than 2 quadrants of the breast, if there are diffuse microcalcifications, that is the feature of ductal carcinoma in situ, if there are persistently positive margins of excision after the initial excision, patient with BRCA1 and 2 gene mutations, if the chest wall is already irradiated, that is also an absolute contraindication, and the metastatic disease. Then we have certain relative contraindications, like poor compliance, collagen vascular diseases, invasive lobular carcinoma in situ, positive family history, central tumor, a tumor with high grade, very large breast, which can cause technical difficulty for irradiation, or very large tumor size, which fail to regress after neoadjuvant chemotherapy. But as we see that with advances in the breast conservation surgery, most of these relative contraindications are no more a relative contraindications. Most of these surgeries, they are being performed now. So different BCS procedures which you can carry on can be a lumpectomy, which is also called a tylectomy or wide local excision, a segmentectomy or quadrantectomy, or a partial mastectomy. But one thing will be common, that all these surgeries, they will be always be followed by radiotherapy. What is lumpectomy? It's a procedure in which tumor is excised and some amount of the normal breast tissue, usually 1 centimeter around it, is also resected along with it. We call it a segmentectomy if the excision is incorporating tissue from nipple right out to the periphery of the breast with at least 1 centimeter of the macroscopic clearance. We call it a quadrantectomy if you remove the entire quadrant of the breast. For example, if the tumor is in the upper outer quadrant of the breast, you remove whole of the upper outer quadrant along with 3 to 4 centimeters of the adjacent tissue along with the skin. Post-op complications could be early or long-term. Early complications could be wound infection, seroma formation, which is collection of the fluid inside the cavity. Pain and numbness in the axilla and arm, shape disruption. The long-term complications could be impaired shoulder mobility and lymph edema because of the axillary dissection. So a question could be, how will you remove a lump that is clinically not palpable and was picked up on mammography? Well, the impalpable lesions, they are better localized preoperatively by guide wires, radioactive seeds, or intraoperative ultrasound. Titanium clips may also be used to mark the site. Moreover, such patients can undergo stereotactic biopsy, which is a biopsy that is taken by the mammography machine itself through a computer-generated program. Since the mammography machine is able to localize the microcalcification or any suspicious area, at the same time, the machine can take the biopsy through that site, and that is called the stereotactic biopsy. After completion and adequacy of the resection of the specimen, you can confirm it, the shape of the specimen, by ultrasound or specimen X-rays can be done. To compare it with the preoperative X-ray or preoperative ultrasound shape, and to check that whether it has been resected adequately or not. How axilla is managed. You will go for a lymph node surgery, and the lymph node surgery in the axilla is done 2 ways, either a sentinel lymph node biopsy or a proper axillary lymph node dissection. Because you want to see that whether the breast cancer has spread to the axillary lymph nodes or not. You will remove these lymph nodes and look under the microscope. What is a sentinel lymph node biopsy? Sentinel means guard. The sentinel lymph node is the first lymph node that drains a tumor. You go for a sentinel lymph node biopsy if clinically the axilla is negative for nodes. And if the axilla is positive for nodes, you will go for a proper axillary lymph node dissection followed by chemo and radiotherapy. So how you go for a sentinel lymph node biopsy? You infiltrate a dye or some radioactive substance in the peritumor area or in the retroareolar region. And then you wait for 5 to 10 minutes for the lymph nodes to take up the dye. And then with the help of a probe gamma camera, you can detect these lymph nodes. And these can be excised and labeled as sentinel lymph nodes. Breast conservation surgery should also be followed and should always be followed by radiotherapy. Because if you don't do this, there are pretty good chances of like 18 to 40% for local recurrence. But if you do radiotherapy after breast conservation surgery, the risk reduces from to 2 to 14%. The whole breast should be radiated with an additional radiation boost to the cavity bed, and it should preferably be marked. The standard whole breast radiation is given for 5 to 6 weeks. Complications of radiotherapy include pneumonitis. It induces cytological changes in the breast like ATP and sclerosis, fat necrosis, and there is a future risk of angiosarcoma. Follow-up for BCS includes regular history and examination every 3 months for 3 years, then every 6 months for 2 years. So it should be a total follow-up for 5 years, and then yearly. Post-treatment mammogram MRI should be performed after 6 months of radiation therapy completion. Annual bilateral mammogram or MRI till the age of 50, and then 3 yearly till the age of 70 should be done. After menopause, DEXA scan can help you for picking osteoporosis. Yearly gynecological checkup, especially if taking hormone therapy or tamoxifen for early picking of uterine cancer. That's all for today. I hope you liked the video. See you next time.